So extrinsic system, it starts from tissue factor. Tissue factor is also known as clotting factor 3. It combines with clotting factor 7, and 3 and 7 is 10, and they activate clotting factor 10 to 10A. And remember that both extrinsic and intrinsic system, their common endpoint is activation of factor 10 to factor 10A. In intrinsic system, remember that clotting factor number 12, it is present in the vascular endothelium, and when this vascular endothelium is damaged, this factor 12 is activated, which then activate factor 11, and which then activate factor 9, and factor 9 along with factor 8, they, and calcium and phospholipid, they activate factor 10. So again, remember these clotting factor 3 and 7, they are a part of extrinsic system, and 9, 10, 9, 11, and 12, they are a part of intrinsic system, and factor 10 is common to both. So when factor 10 is activated, it then lead to conversion of prothrombin to thrombin, and thrombin then convert fibrinogen to fibrin. And this fibrin is then deposited in the platelet plug and lead to the formation of a blood clot. So
there are two mechanisms which are going on. There's one which is like conversion of fibrinogen into fibrin, and then from prothrombin to thrombin, and then fibrinogen to fibrin. And there's one which is factor 12, which is converted to factor 12A, and then it is directly converted to fibrin. Sorry, it's a bit confusing.
You are talking about this point, right?
Yes.
So there are two functions of thrombin. One is it convert fibrinogen to fibrin, and the second function is that it activates factor 13. It's not factor 12, it's factor 13. And activated factor 13, it lead to cross-linking of fibrin.
Right.
So the function of factor 13 is cross-linking of fibrin, not production of fibrin. The production of fibrin is a function of thrombin.
Right.
And thrombin is activated by factor 10. So
Right.
this common endpoint is very important, because most of the anticoagulant drugs such as heparin and low molecular weight heparin and fondaparinux and direct acting oral anticoagulants, they act at this point, they inhibit this factor 10A. This direct acting, they directly inhibit this factor 10A, and indirect inhibitors such as low molecular weight heparin and unfractionated heparin, they indirectly inhibit this factor 10A. They combine with the antithrombin, they form a complex with the antithrombin 3, and then they inhibit the factor 10A. So that's why they are called indirect acting anticoagulants, that is heparin or low molecular weight heparin and fondaparinux, etc. And direct acting, they directly combine with this factor 10A and inactivates it. That's why they're called direct acting oral anticoagulants. So the first cause of a bleeding disorder is idiopathic thrombocytopenic purpura. That is known as immune thrombocytopenic purpura more recently. So we discussed that immune thrombocytopenic purpura can occur after upper respiratory tract infection. In children, usually it is preceded by an infection. So in immune thrombocytopenic purpura, there is destruction of the platelets due to production of autoimmune antibodies. So what will happen if there is low platelets? There will be skin and mucosal bleed, such as skin bleed will manifest as a purpura or bruises, and mucosal bleeding will present as epistaxis or menorrhagia or hematuria as well. And what will be the lab finding? In the lab findings, platelet will be low and bleeding time will be increased because of low platelets. So whenever there is low platelets in the body, bleeding time will be increased. So an increase in the bleeding time means either platelets are normal or they are dysfunctional. So remember this point as well, that bleeding time indicates uh, the function of and the quantity of platelets. So increased bleeding time means there is problem with the platelets. So clinical manifestation of problem with the platelets, they include skin and mucosal bleed, and lab investigation include increased bleeding time and low platelets. The treatment is, because it is an autoimmune condition, so prednisolone can be used. It will suppress the immunity and it will help in improving the symptoms. IVIG, they can be helpful as well because they will combine with the antibodies that are formed against the platelets. And the third option that we have is life-threatening hemorrhage. Uh, if there is life-threatening hemorrhage and platelet count is less than 20, then emergency platelet transfusion is required. Remember that platelet transfusion is not that much beneficial in ITP, because if we transfuse platelet, the antibodies that are formed against the platelet that will be present in the blood. So that's why platelet transfusion is only indicated if there is life-threatening hemorrhage and platelet count is less than 20. Our first line treatment will always be prednisolone. So immunosuppression is the main stay of treatment. If symptomatic and platelets less than 20, then prednisolone 1 milligram per kg per day will start, and then we'll reduce the dose slowly and we'll keep the platelet count above 30. It takes a few days to work. Now, if this immunosuppression fail in the form of steroids, then other immunosuppressions such as azathioprine or cyclophosphamide, they can also be tried. So steroids, basically immunosuppression in the form of steroids or azathioprine or cyclophosphamide. Platelet transfusions are not used except during if the patient need to undergo splenectomy or if there's life-threatening hemorrhage, because these platelets will be quickly destroyed by the autoantibodies. So that's why there are only two conditions in which platelet transfusion in patient with ITP is indicated. One is splenectomy and the second one is life-threatening hemorrhage. And IV immunoglobulins, they may temporarily erase the platelet count. And the indication for IV immunoglobulins, they include surgery and pregnancy to temporarily raise the platelet count. Now there is a drug, Eltromopag, that is a thrombopoietin receptor agonist, and that stimulates the production of platelets. So a question was asked about a patient presented in the previous exam in the November attempt, I guess. There was a question about ITP and all of them were given in the option: prednisolone, IV immunoglobulins, and platelet transfusion. So that's why it's important to remember when to go for which option. So our first line will always be prednisolone, immunosuppression in the form of prednisolone, azathioprine, or cyclophosphamide. If prednisolone does not work, then we will try the other uh, immunosuppressant. Immunoglobulins will only shortly raise the platelet count, such as during surgery or in pregnancy. And platelet transfusion is only indicated in two conditions. That is, patient who are undergoing splenectomy or a patient with a life-threatening hemorrhage. ITP usually is common in children, and it is typically acute in children, while adult it present in a chronic form. And ITP usually occur after an upper respiratory tract infection or even after vaccination. Some children can develop ITP. It is a self-limiting disease which usually resolve 1 to 2 weeks after its onset. What is Evans syndrome? Someone with idiopathic thrombocytopenic purpura in association with autoimmune hemolytic anemia. So someone with antibodies against platelet and antibodies against RBCs, your diagnosis will be Evans syndrome. In other words, thrombocytopenia with a positive direct home test, your diagnosis will be Evans syndrome. So key points in this topic include if a patient presents with isolated thrombocytopenia and a history of upper respiratory tract infection, this word is important, isolated thrombocytopenia. Isolated thrombocytopenia, you will always suspect ITP.
So isolated means like among all the other investigations, only the
Yes,
platelets
all the
will be.
other investigation like prothrombin time, partial thromboplastin time, fibrinogen, all other lab investigation, hemoglobin and WBC, they all will be normal. Only
Okay.
there will be thrombocytopenia on complete blood picture.
Right.
So what you
So
said
this
about the immunoglobulins, one in pregnancy and the second one is
surgery.
surgery. Okay.
When you need to require, because steroids or immunosuppressive drug, they will take 2 to 3 days to work. So if there's an emergency situation, such as a person is pregnant and she need to deliver a baby, then we'll go for immunoglobulins because we cannot wait for 2 or 3 days so that these immunosuppressive drugs can start working, and then we'll do our thing. And the second one is surgery.
Okay.
Because for surgery, again, uh, we need a high platelet count just temporarily. After surgery, we can start the steroids. But for that time, for surgery or during pregnancy, we can use IV immunoglobulins.
Okay, sir.
So someone with isolated thrombocytopenia after a history of upper respiratory tract infection and manifestation of platelet deficiency such as skin and mucosal bleed, you will suspect ITP. On the lab, there will be thrombocytopenia and bleeding time will be increased. Remember this, that bleeding time is basically, bleeding time is to check the function of the platelets, or it detects the problem with the platelets. So this was all about ITP. Bleeding due to disorder of the platelet, that is ITP. So in this disorder, there is peripheral destruction of platelets. There are some other disorders, platelet disorders, which can occur due to underproduction of the platelets, such as leukemia and lymphoma. That we will discuss in leukemia and lymphoma. For now, we'll move on towards our next topic, that is bleeding due to defect in the clotting factor or deficiency in the clotting factors.